Afternoon. Thank you for joining us today. My name is Lori Smetanka, and I am the Executive Director at the National Consumer Voice for Quality Long-Term Care. Thank you for joining our webinar this afternoon. Our topic is avoiding inappropriate use of antipsychotic drugs, knowing your rights. A few housekeeping items before we get started with the webinar. First, this webinar is being recorded. The recording, the PowerPoint, and the materials will be available afterwards on the Consumer Voice website. As well, links to the PowerPoint and an article, another piece of material, are also available in the chat box on your control panel. You can download that at your convenience. All of the participant lines will be muted during the webinar, during the presentations. You can write questions into the question box on your control panel. After the presentations, we will get to as many questions as we can in the time allowed. I'd like to introduce the speakers for today's webinar. They include Kelly Bagby, who is the Vice President for Litigation on Health, Housing, Hunger, and Human Services for AARP Foundation. And also, we're pleased to welcome Robin Keller, who is the daughter of Bobby Tweed, who resided in a nursing home. Robin's going to share her father's story and her family's experience with antipsychotic drug use. And as I mentioned, I'm Lori Smetanka. Katie, next slide, please. We are going to talk today about the use of antipsychotic drugs in individuals, primarily with dementia, living in nursing homes, and the effects that that can have on them. What we know is that more than 179,000 residents, most of them living with dementia, are given or prescribed these antipsychotic drugs despite the fact that they have no clinical diagnosis for which the drugs are approved. So, for example, the antipsychotic drugs generally are approved for conditions such as schizophrenia, and they have not been approved by the Food and Drug Administration for treating symptoms of dementia. They're being used off-label in these individuals. The drugs have a sedative effect on most people. They alter their ability to interact with others, but they also increase the risk of falls, the risk of strokes, and they can be very dangerous for people who are living with dementia. And in fact, the Food and Drug Administration has issued a black box warning on a number of antipsychotic drugs, indicating that they increase the mortality in elderly patients with dementia-related psychosis. And should not be used or should be very carefully monitored, certainly, and people weaned off of them if they are being used with these individuals. So unfortunately, they're often also administered without informed consent. Neither the resident nor their legal representative often know the drugs that are that these drugs have been prescribed, nor why they're being used. And they also are not generally given the information about the risks of these drugs and that they have been issued these dangerous warnings. So when drugs are used to treat behavioral symptoms in place of good care, Katie, next slide, please, or they're used for staff convenience, they're generally called a chemical restraint, and that's prohibited by federal law for people that are living in long-term care facilities. And that's what we're talking about today. When these drugs are not being used for clinical diagnoses, when they're being used to treat symptoms in place of good care and or for staff convenience. And so what we know is that there's been some work done in this area over the last several number of years. There have been studies that have been written about the use of these drugs, highlighting some of the concerns. They've been published by the General Accounting Office and the Office of Inspector General. They also have there have been a number of private studies and research done, including most recently by Human Rights Watch, looking at the use of these drugs in residents, particularly those with dementia, all highlighting the concerns of their use. There have been campaigns across the country to reduce the use of these drugs in people, but we are still, as I mentioned earlier, looking at more than 179,000 people who are still being prescribed these drugs and having them used despite the fact that there is not a clinical diagnosis. So we at the Consumer Voice, next slide, have partnered with the AARP Foundation to launch a consumer education campaign, Avoiding Drugs Used as Chemical Restraints. And we are excited about launching this campaign and focusing on how to educate long-term care consumers, their family members, and their advocates about the use of these drugs, talking about not only what they need to know about them, what their rights are, but what good care practices are also. Next slide, please. As I mentioned, we're thrilled to be partnering with AARP Foundation on this project. They have been very active in this space around looking at the use of antipsychotic drugs in elderly people with dementia, and Kelly will be talking about that in a little bit. Next slide, please. As we look at the focus of this campaign, we have three primary objectives. One, as you can see, is to raise awareness of the dangers of these drugs, particularly with people with dementia, looking at why they're being used and what other types of strategies should be used instead. We're looking at not only strategies but solutions for how individuals can exercise their rights and obtain quality care without the use of drugs. And we want to equip the consumers and their advocates with the tools and knowledge that will really help them obtain better care and to help advocate for good care without the use of these drugs. Because what we know is that a number of providers, lots of them, are providing good care without the use of these drugs, and that is what we want to see for all residents. Next slide, please. Some of the things we'll be doing as part of this consumer education campaign is developing resources for consumers that they can use that can help educate them about this issue and about good care practices. We're developing an advocacy resources toolkit as well that Ombudsman and citizen advocates and others can use to educate consumers as well as staff. We're focusing on outreach and communications efforts to get the word out to consumers and advocates about this issue, thinking about how we can really reach as many people as possible. And we're looking for assistance from others, for partnerships with other organizations and folks who will help get the word out about these issues and help educate consumers about what their rights are, as well as about what good care practices look like. And as we're doing with this webinar, we're also going to be developing other educational programming around this issue to really help educate and support consumers and their advocates as we work collaboratively to reduce the use of antipsychotic medications to really get to a point where they're not being used as a means of restraining residents chemically, and they're not being used instead of good care practices. So that's one of the reasons why we wanted to do this webinar today, is to get started on launching the campaign, to share information and resources about this issue, and to start talking about what rights are for consumers who are facing challenges with respect to the drugs that are being prescribed. So we're going to start, though, by hearing a personal story from Robin Keller. If you can go to the next slide, please, Katie. Robin, as I mentioned, is the daughter of Bobby Tweed, who was a resident in a long-term care facility, and Robin is going to tell us the story of her father and her family as he was receiving care in a long-term care facility. So, Robin, let me turn it over to you.
Thank you so much, Lori. I really appreciate the opportunity to share the story about my dad. Like most daughters, I adored my dad. He was my hero growing up, and he and my mom were high school sweethearts. When she passed away, they had been married for 52 years. My dad had worked at the same company for 38 years when he retired. He was a deacon in the church since he was 27 years old, and he was also the kind of person who volunteered in the community. He was a volunteer fireman. He went to EMT training and volunteered for that. And anytime anything was going on in the community, my dad was involved, whether it was a horse show or a parade or cooking hamburgers at the football game, you could find my dad there. After my mom passed away, maybe about a year or so later, my dad started showing signs of what we later found out was dementia. Took him to several doctors, and the diagnosis was just that. So he was put on medication that's approved for Alzheimer's and dementia, Aricept, and later Namenda was added to that. And on that medication, along with caregivers in his home, he was able to stay home for almost 10 years. And, you know, we had great caregivers, plus the fact that people in the community would bring meals, would check on him, would, you know, do the kinds of things that happens in a small community. But after that period of time, then Dad became a little worse in that sometimes he would wonder at night, or, you know, as his memory deteriorated, his caregivers told me they felt that he needed more care round the clock. We had somebody there 12 hours a day, but it seemed like it was a little more. And admittedly, after 10 years, it was also becoming financially difficult to pay for somebody to be there all the time. So after much prayer and discussion and agonizing, which most families do before they make the decision that their loved one has to go into a nursing home, we began trying to find a nursing home for my dad to go to. And, you know, I did research. And one of the things that, one of the things we found out is there was a local nursing home that had great reviews in U.S. World News and Report. Several of my dad's friends were in the nursing home, and also his nurse on the wing that he was on was from his community. So we felt fairly comfortable moving him into a nursing home. And he moved in January, and for about 7 months, everything was wonderful. The picture that you see on the left was in July of that same year. My dad came out of the nursing home. We had a birthday party for him at my brother's house. And he was walking and talking and feeding himself and able to socialize. He was doing good. And everything was fine.
But the following month, which was August, we got a call from the hospital, from the nursing home, that Dad seemed agitated and that they would really like to transport him to the local hospital.
Robin, I'm sorry. We are suddenly getting a lot of feedback. Can you try speaking again?
How about now?
Oh, that's better. Thank you.
I am so sorry. I was saying that in August, I got a call. I was my dad's power of attorney, and I'll back up just a second to say that when he moved into the nursing home, I spent a lot of time with the staff talking to them about, you know, that I had his power of attorney, that I was the one they were supposed to call and get permission from if any changes happened, if anything needed to be done, if anything went on. And I was constantly calling the nursing home, checking on him. I lived about 400 miles away, so it was only about once a month that I actually was able to make the trip. But my brother, can you hear me now?
Yes, we can hear you now. Thank you.
Okay, I just saw a message that somebody said they couldn't hear. My brother lived in the same town, and I had a cousin who would go by and spend time with Dad, so lots of folks were there. But in August of that year, it was the 8th month Dad had been at the nursing home, I got a call that he seemed agitated and that they would like to transport him to their local hospital that they had an association with for evaluation. They had an area of the hospital specifically for seniors, and were specifically geared up for that. So my family agreed to do that. And while he was there, my brother went by several times and was told everything was fine. I talked to the doctor and found out that my dad had a urinary tract infection. So I called the nursing home and asked if they knew that, and they said no, that in fact it was their policy to check for that before they would ever move someone to the hospital, because that can cause aggression and irritation, agitation. So Dad was there just for a few days, and when he came out, he went back to the nursing home, and I would call and check on him frequently. My brother would go by, my cousin would go by. But then one day my cousin called me and she said, "Robin, I'm really concerned. I've been by in the last 2 weeks about 5 times. And every single time I'm there, Bobby's asleep. I can't get him awake. I can't, no matter what I do, I can't waken him. So she said she had talked to the nurses and they had said, oh, that's just pretty typical with the disease and not to be concerned about it, but she was concerned. And so what happened was I made a call to the nursing home and I asked to get a list of the medications that my dad was on. They gave me the list. It was at that time that I found out my dad was no longer on Aricept. He was no longer on Namenda, but instead his medications included Geodon. It included Depakote, Paxil, and Ativan, a cocktail that was, to me, shocking. And so some of these drugs I'd never heard of. So I started doing research. And I found out that there was some terrible side effects, especially Geodon and Depakote, and that there were black box warnings that these drugs were not to be given, or they weren't designed to be given for elderly people with dementia. So I immediately wrote a letter to the nursing home. I faxed it that day, telling them that I was disappointed and shocked that they would give those drugs to my dad, that they did not have my permission to do that, and that I wanted those drugs removed. And I specifically said in accordance with recommendations, because some of these drugs have to be gradually removed. Well, the next thing that happened is that I called back, that this was over a weekend, so I called back on Monday and I was told that the person who prescribed these drugs would not be back for a week and that there really wasn't much they could do until then. And so my dad would continue to get these drugs for another week. And at the end of that week, there was a group of people who called me from the nursing home, almost like a panel, a team. And they tried to convince me that I needed to keep my dad on these drugs, that I should do more research, that these drugs were helpful and beneficial. And I basically said, you know, I'm really sorry and I appreciate your thoughts, but the FDA says not to do it. The people who make it say not to do it. So there's really nothing to discuss. According to his file, they abruptly stopped all medication the following day. And so that's not in accordance with what you're supposed to do. And 3 days later, I went to visit my dad. The picture that you see on the right is how he looked when I got there. And I was shocked at his condition. I called his physician. I asked him, again, it was a weekend, so I left multiple messages saying, could you please run some tests? I want to know what's going on. Can you go by and see him? Tell me what's happening. So the doctor called me back, assured me he would go to the nursing home and that he would check on Dad. He ordered blood tests, and a couple of days later, I got a call from the nurse that was from our town, and she said, Robin, we got the labs back and things are really bad. She said, we've got IVs running and I've called the doctor and he's going to be here within an hour. So what happened then is, you know, I obviously went to where my dad was, and at this point in time, they did have IVs. There was a nurse sitting with him. He was in constant motion. His feet were moving. His arms were moving. I was told he had fallen out of the bed. The nurse said he wasn't like this when I left. You know, I've been on vacation for a week, and basically he was not moving at all, and now he's constantly moving. The labs indicated that he had renal failure and he was severely dehydrated. In looking at his files, I found that he had lost 35 pounds in about 5 weeks. He wasn't able to communicate. And the doctor at the nursing home assured me that they would have someone with him 24 hours a day, that they would do whatever was necessary to get these drugs out of his system, and that they would put him back on that Aricept and Namenda. He asked me to trust him with the care, that there was more they could do at the nursing home than could ever be done at a hospital. And that was basically because they had someone who could sit with him 24 hours a day where the hospital wouldn't. And that they would have labs every single day to check on him. So for the next couple of days, things started improving. But then I went the third day and got to his room. There was no nurse and no IV. And basically I found the doctor had left for 3 weeks, and they were told they had to wait to do anything. So I went to the desk and I asked my dad to be transported to the hospital. He was transported to the hospital. When I got him there, the doctor in the ER asked me to call the family in, that he felt that he had about a 50% chance of survival through the night. Fortunately, he did get stabilized. He was in the hospital for about 10 days. To again get the drugs out of his system. He was not able to eat. And the other thing was that his legs were constricted from being almost in a fetal position for weeks. And they told me it would take a very long time to correct that. After a couple of weeks in the hospital, they told me there was not really anything else they could do. And so I was able to get him admitted into another nursing home where they appeared to take really good care of him. I stayed with him for about 4 or 5 days. And then within 2 weeks later, I got a call from the nursing home that he had taken a turn for the worst. And 3 days later, he was gone. So the death certificate basically said multi-symptom failure, which I'm told is pretty common. But that's what the drugs did to my dad. I feel 100% certain that they were the cause of his death. And one of the things I will tell you is I was just determined that these people were not going to get by with this, that things had to stop, things had to change. And fortunately, I was able to find Kelly, who's getting ready to talk to you, Kelly Bagby at AARP, who was absolute angel. She agreed after she heard about my dad to be co-counsel in a lawsuit against these people that did this. My goal was to raise awareness, to let other people know that you can't just sit by and let them do whatever they want to do. You've got to stand up. So that's pretty much my story. I appreciate you letting me share it with you, and I will turn this over to Kelly.
Thank you so much, Robin. It's so breathtaking every time I hear you tell that tale. I mean, I just want to ask a quick question before I start. Is there information that you wish you had known to better prepare you for what it was that you went through with your dad when he was getting admitted, and then when you discovered that these things were happening?
Well, one of the things, and I appreciate you asking that, yes, one of the things certainly that I would recommend to anybody to ask a lot of questions, to ask to see your loved one's file, to pick it up and read it, to make very clear that never under any circumstances are they to give medication to your loved one without permission, including even increasing or decreasing doses. And if they do tell you they want to give a drug, don't just assume because a doctor said so that you should blindly accept that. Research what the drug does, and then make sure that they're constantly monitored after the drug is administered to see that there's changes. Like Daddy lost the 35 pounds. And I asked them, well, didn't you notice something was wrong when he was constantly losing weight? Because they have a little weight thing in his chart. And they said, well, yes, we did notice that, and we changed his diet, but there really wasn't anything else we could do because you had signed a DNR.
Mm.
So if you sign a DNR, make sure you fully understand. My understanding was a DNR was if he went into cardiac arrest or, stopped breathing, that they weren't supposed to help him, not if they were starving him to death, that they weren't supposed to do anything. So, you have to be firm, you have to not be bullied, and you have to continually ask questions. The other thing that Kelly said I did that was good was when Dad first moved in, the paperwork they had given me had paragraphs for arbitration and mediation in them, and I struck through those and refused to do that. And that's just basically kind of from my job that I do in my life. Those are terms that we don't agree to because they're usually not in your favor. So those are the things I would recommend, Kelly.
Yeah, those are excellent recommendations, Robin. I appreciate you sharing those with folks because not everybody realizes that Xing out those arbitration provisions is a possibility. And really the reason we were able to bring suit on your behalf was that that you had done that. That really made this much easier for us. So can you go to the next slide, Katie? So obviously we've all talked, Lori and Robin have both talked about the need to raise awareness and understand the problem. I think, we can't put too fine a point on that because I feel like so many people, because it's the way that healthcare is presented to us, it's presented to us as a take it or leave it proposition. Not many people are able to, fight as hard as you need to fight in these situations for your loved one or yourself. And so the raising of awareness is critical so that we're empowering each of you that's listening to go out and empower other people to be able to fight these battles on a day-by-day basis. We're also going to discuss more advocacy strategies. Robin and Lori have both given you a good few for holding people accountable and for creating deterrence. Like ultimately, we don't want anyone to go through what Bobby Tweed went through. We wanted to have deterrence so that we're not trying to forensically look at this and say, well, how did that happen? We want to get in there and empower people to prevent any further use of chemical restraints. And then we also want to engage in a dialogue about other strategies that, many advocates are on the line. And we'd love to hear what you guys have done and what you're learning as you're, trying to fight these battles in real time on a day-by-day basis. Next slide, Katie. So we're going to talk a little bit about these drugs. So, psychotropic drugs are a godsend for people who have, can be a godsend for people who have mental health needs that can be treated with these drugs. The problem is when they're given to people who do not have the underlying mental illness for which these drugs were created, they can have dire consequences. And so, we are not demonizing antipsychotic drugs, but we are saying they should be used for people for whom they're approved. And so when they're used with people with dementia, the consequences can be, very, very dangerous. It exposes people's immune systems to more infections. You'll definitely have increased sedations. That's kind of the reason they're used with people in nursing facilities. You'll have lethargy. People will become unsteady. They'll start having more falls, as Robin described with her dad. And because they're not able to move as much, they're relegated to a wheelchair or a bed more often, and they start to have an increased risk of getting bed sores. You'll have Parkinsonian symptoms, which what Robin was describing with her dad with his rapid feet movements, but you can see that through all parts of a body. You start noticing tremors in the hands or even rigidity where they look like they're not sitting comfortably anymore where they were before. And body restlessness, like in Robin's dad's case, he was shuffling his feet so much he wore some of the skin off the bottom of his feet, and he didn't even realize because he couldn't stop moving. You have a decreased well-being, as you can imagine. A loss of appetite is always, it's something we see a lot in a lot of these cases. Also, dehydration is a very common problem. Social withdrawal because they just don't feel like doing anything. And what is part of the reason why this gets so confusing for people is there's an accelerated cognitive decline, and that is sometimes mistaken as a natural consequence of dementia, which it is not. If someone starts, is talkative and social, 1 month and is really not the next month or even week, then you need to ask for a full, workup. What are they giving? What are the possible reasons? It might be that the cognitive decline is because of an underlying physical illness, but it could be that there is a problem with the medication. Can you go to the next slide, please? So the FDA has approved the use of 10 what are called atypical antipsychotic drugs for treatment of schizophrenia and bipolar disorder. And again, as I said, those are for the people who need the drugs and who understand, make informed decisions about using those drugs to treat their illness. They can be a godsend. Next slide. But the FDA has indicated that these drugs are should have a black box warning, which is called the black box warning because literally the warning label has a black box around it to draw attention to it. And it's in the package insert. So, when you see the drugs in a nursing facility, you can't tell that they have a black box warning. It's only when you see them coming out of the box. And the box is very clear that, can you go to the next slide? The box is very clear that these drugs, which I put in both the generic name and the brand names here, these are some of the drugs that have this black box warning. And the warning is quite dire when you see it, but I think one of the things that we're gonna do with Consumer Voice is sort of have this list put out there so Ombudsman, family members can always, it's hard I don't remember all these names. I recognize the brand names, but the generic names are not easy to remember. And so we want to make sure that people have access to this information at a ready, like a pocket something or other that you can go into a nursing facility with, so that if you have a resident who has dementia and you see they're on Seroquel, Zyprexa, Geodon, any of these things, you want to ask questions. Next slide. So here's what the label, this is a label for Geodon, which is one of the drugs that Robin's dad was on. And it's very clear that it causes an increased risk of death. And so this is an increased risk of death. The test that this is based on, the FDA test, is really not even for very elderly people. It's people, I think, in their early 60s. But you can imagine as you move on to 70-year-olds and 80-year-olds that this could be a real, the increased risk of harm accelerates as somebody is older and has a more complicated set of, basic organic medical problems that they're facing. With Seroquel, it talks about that there is an increased risk of death, and it is just clearly not approved for elderly patients who have dementia-related psychosis. And I want to talk to you a minute about dementia-related psychosis, because sometimes, if you could change the next slide, sometimes you're going to see, I think I'll talk about it in a minute, what's called diagnosis creep, where in order to justify giving one of these drugs, you might see the dementia-related psychosis suddenly pop up in a file. And you want to be extremely wary of that, because that sometimes is someone changing a diagnosis to fit what it is that they want to give the person. And that is not a legitimate diagnosis. But pharmacists are supposed to really look at what the diagnosis is before they fill a prescription for these drugs. And I think it's key that you're always matching up the diagnosis with the drug and asking questions like, well, where did that diagnosis come from? If they only just got the diagnosis of dementia-related psychosis in the last, during this admission at the nursing facility, for example, then that is a little suspect. So antipsychotic drugs are being prescribed in nursing facilities, despite the fact that they're not approved by the FDA. And so we have to wonder, why is this happening? And, a lot of it, these are called chemical restraints because they restrain people's behavior and personality in a chemical way. But the reason, unfortunately, the cynical reason, and I think the reality reason why this is happening, is that people who are more docile don't require as much staff interaction. And so it makes for, especially if you have an overcrowded facility, it makes for an easier shift for the staff. Now, doctors are allowed to prescribe medications for off-label use, and sometimes, we consider that innovative depending on what it's being used for, right? So there are certain things that we think, okay, if you can use a drug like this to treat headaches, then maybe that's not such a bad thing. But when you don't evaluate the risks and the alternatives to drug treatment, and you don't get informed consent, then you start creating a perfect storm of dangerous conditions. Next slide, please. So this is older data because we're using federal reports for this, but these are GAO studies and Office of the Inspector General studies that we're using. So in 2012, 38% roughly of people in nursing facilities had dementia, but 33% of people who had dementia and who spent more than 100 days in a nursing facility were prescribed an antipsychotic drug. That's a lot. That is a lot of people. A third of the people who spent more than 100 days in a nursing facility with dementia are getting an antipsychotic drug, and that is not an on-label treatment. So Medicare started looking at the costs of that because that's, Medicare is paying for a lot of that off-label use, especially for those first 100 days. There are a significant number of Medicare claims. So this is not only, cruel, illegal, counterproductive, not a good treatment, but it's also costing the taxpayer a significant amount of money. Next slide. So again, we're going to ask the hard questions. Why is this happening? Well, we believe that it's happening because it's the result of a very effective off-label promotion scheme put into effect by many different pharmaceutical chains, nursing facility chains, pharmacy, nursing, long-term care pharmacy chains that allowed for kickbacks to go back and forth, and they were incentivizing people to use these drugs with nursing facility patients because they're a captive audience. It's sort of a perfect place to do this. Now, Depakote again is not one of the drugs with an off-label notification, but it was very, very effectively promoted in nursing facilities to the extent that it actually had a $2.8 million settlement to settle these kickbacks. So the kickbacks were the pharmaceutical company would pay Omnicare, which is the pharmacy company, to make sure that Depakote was given in as many facilities as they could, and they were getting kickbacks back and forth, and Omnicare would order those drugs and get them into the many nursing facilities where they were the long-term care pharmacy. Next slide. So they had, this very multifaceted scheme. They would have rebates. They would have straight kickbacks as well. They had special programs and materials where they would bring in the pharmacists and train them on how to do this and send them on nice trips and everything. So it was very multifaceted. This was a second scheme that they were basically caught at. Next slide. Johnson & Johnson similarly was promoting Risperdal, which is this is an antipsychotic drug with a black box warning. And they had a $2.2 billion in civil fines. That's a stunning number. But you think about how many people were given Risperdal, and it was probably money well spent because they got a lot of these drugs into these facilities. Eli Lilly had a similar settlement for $1.5 billion for getting Zyprexa into nursing facilities. Next slide. So here's the kicker. These are not good treatments. And so the idea that they're being pushed into nursing facilities is especially offensive when you think about the consequences, but also that there are good treatments that you can use with people with dementia that don't involve drugs. And so there are, you know, for the folks who are on this call, I presume you're on the call because you understand how, you know, how people who have dementia often, you know, manifest their behaviors in the world. But there are a lot of ways that, you know, you can address behaviors are, they're basically symptoms of dementia that don't involve drugs whatsoever. But first and foremost, you have to evaluate whether what the behavior is trying to communicate to you that they're uncomfortable because there's an underlying medical problem. And an underlying medical problem should be treated with medical procedures, medical interventions, not that they should be drugged and basically masked. Because once you mask the communication, that even the behaviors that people are telling you, they're trying to communicate something, and all communication should be listened to. And when you put these drugs on top of the communications, you're just dampening it down, and the person loses the ability to tell you what really is the problem. Can you go to the next slide? So Robin talked a little bit about, and Lori talked about it too, about this idea of informed consent. And so who gets to decide whether you're given these drugs or not? I mean, who gets to decide whether you should have a non-drug treatment or you should have a drug treatment? Well, the Society for Post-Acute and Long-Term Care Medicine is basically the association of people who are medical directors in long-term care. They believe that we should not be using antipsychotic drugs until we have first eliminated that there's a medical problem that is causing the manifestation of whatever you're seeing on a day-to-day basis. And you have ruled out whether there are non-drug treatments that would effectively address the behavior. Next slide, please. So I'm going to talk, this case actually is a good explanation of the informed consent discussion. If you think about the fact that if you're the physician or the medical consult who is saying, I want to give your loved one this drug, how does that informed consent conversation look if the drug that you're prescribing has a black box warning that says it could kill the person you're giving it to? I mean, really, you have to ask yourself that question. How would a doctor present this to, how should the doctor have presented that to Robin in advance of giving the drugs? The problem is it should always be in advance of giving the drugs. But if they were to tell Robin, you know, that we want to give your dad Geodon, and it has a black box warning, and it could kill him because he doesn't have a diagnosis that supports that drug, that should be the informed consent conversation. Then Robin could say, well, why would you do that? Why wouldn't you try something? Is there anything else? Is there anything else at all? Is there a non-drug treatment? Is there a drug treatment that might be appropriate, that's on label? Or is there, you know, have you tried to talk to him? I find that if I take him to another room and redirect him to something, you know, whatever it was that was upsetting him no longer upsets him. There are a host of interventions that do not involve drugs that should have been tried. So in this was our first case that we did in California. It was a class action, and we unified the class around the fact that one doctor was prescribing drugs and never got informed consent for hundreds and hundreds of residents in the facility. Next slide. I don't know if there's a slide on here, but I want to give credit to Jody Moore in California and her partner, Mr. Johnson, who brought the case with us. They brought the case, and they kindly let us join, but it was an instrumental case in really uncovering the prevalence of this problem. So Kathy Levine, like Robin, was the legal power of attorney for her mom. And she was admitted to this facility after having broken her hip. And so she was trying to get better. She was just admitted for rehab, but she was uncomfortable because of the broken hip, and she kept shifting in her wheelchair. They tied her arms to the chair to try to keep her from getting out. And when that didn't work, they decided to prescribe a host of drugs, but they never contacted her daughter, who was the medical power of attorney. They gave her, I think over the course of a 2-week period, 11 drugs that had not been prescribed before. Can you go to the next slide? Ms. Levine just, was going and visiting and realized that her mom just became completely incoherent, and, she couldn't make heads or tails. She didn't sometimes even recognize her daughter. Within a few weeks, Kathy took her mom out of the facility and took her into the hospital to try to get her off the drugs, but her mom died shortly after. Next slide. So Ms. Levine sued, we do have Greg Johnson and Jody Moore as our co-counsel, and we brought a lawsuit on behalf of every person who had been prescribed these drugs by this doctor without informed consent. And they were needlessly medicating people, they were not getting informed consent, and they were violating state and federal law. And there's in subsequent lawsuits that we've brought about this, we've also pointed out that this is a battery. If an unwanted touch into my body is a battery on me. And if you're prescribing drugs and that are mind-altering drugs, no less, for people, and you do not have legal consent to do that, it is a battery. Next slide. We settled that case and managed to get money for the residents that had suffered. At this point, most of them had passed away, unfortunately, and for their estates. And we importantly got a monitor to monitor the facility for 3 years to ensure that this behavior truly changed and that the informed consent process was meaningful and really gave people the right to have the information they needed before anyone ever prescribed the drugs. They had to have these informed consent conversations at the beginning of the relationship, not after the fact. Next slide. So after this, the AARP bulletin, there's another bulletin article in your materials that Lori has indicated, but there is an earlier one from 2014 that really did, I thought, a very good job sort of exposing this process and the nature of the kickbacks and how this became such a prevalent practice. It's just too prevalent. We wrote a letter to AARP to CMS and the FDA demanding that they also, really try to be much more aggressive in their enforcement actions on this because it is a national problem. But we also got contacted by many, many people, including Robin, and that helped us to bring another set of lawsuits on the subject so we could continue to really make sure that there was a constant focus on this issue. Next slide. So you've heard more about this, and the one thing I want to talk about this is ageism. I think it's difficult sometimes to find counsel for people who go through this because the nursing facility industry will try to pretend like this is the normal process of aging, and that people with dementia they're gonna die, and they're gonna have this, and of course we're all gonna die. The question is how you die. Do you have to die in such pain, and do you have to die silenced, and do you have to die restrained? No, you do not. And so all of us are going to die, that is true, but you have the right to die with treatments that are appropriate for you, if that has to be it, or you could maybe live, maybe Robin's dad had years left in him if they hadn't done this. We will never know, but that is basically a function of ageism when you say that because someone's in a nursing facility, we don't need to do informed consent for them. Next slide. So I think there was one of the comments that I saw someone make was about the medical directors and attendings that are not necessarily employed by the facility, which is true. But there's a lot of rubber stamping that goes on where if there's an outside consultant that makes a diagnosis, makes a recommendation about medications, then the medical director will just say, yeah, sounds good. that also happens with nurses within the facility, and that's what happened in Miss Levine's case. The nurses were saying, we can't control her. We need you to fax over an order for Zyprexa, and the doctor would just promptly fax over an order for Zyprexa without ever seeing the resident. And then diagnosis creep, I've already talked about that, but that's when the diagnosis shifts suddenly, and then all of a sudden you'll see Zyprexa or one of these other drugs that are not appropriate for dementia, but they'll have a diagnosis of something that might look less shady. Next slide. So we have the 2017 materials in here. If Lori, if people want it, we can also send the 2014, which I think has a lot of the historical background of why this became so prevalent. Next slide. So the Robbins urged you to look at records and everything, but also ask for the policies. Every nursing facility has to have policies on when they'll give medications, informed consent, when how they will communicate between the doctor and the staff, and ask people. I know this is probably intrusive for families, but not for ombudsmen. Like, check the knowledge of the people on what their policies say. We were shocked in one of our cases when we were deposing different staff in the facility. And every time we would say, whose job is it to get informed consent for antipsychotic drugs, everybody pointed at another person, another whole class of staff. And that is really a problem. Next slide. So the piece that Robin also mentioned, and I really want to emphasize this, is that many facilities will administer these drugs and will not follow up on, won't notice even that the symptoms that are clearly identified as risk factors in using these drugs are just manifest all over their facility. So somnolence, so sleepiness, people being confused, people being restless, people shuffling, falling, people not wanting to eat, people having a hard time swallowing, and Parkinsonian symptoms. Those are all things that if any single resident is manifesting it in a facility, the facility should be calling a care planning meeting, of asking the family to come in, really reevaluating, why is this happening? These are not normal things to just suddenly start happening with a resident. Next slide. So part of the reason why Consumer Voice and Foundation, ARP Foundation, are doing this is we are very passionate that the way to change the prevalence of this is a real cultural transformation, that we need to make sure that the direct care workers, the physicians, the people who are the pharmacists, that they're all a little bit afraid to continue with this practice, because this is abuse and neglect. It is a chemical restraint, and we need to all be able to point it out and call it out for what it is, because that's the only way we're going to be able to change the culture. Can you go to the next slide? So the long-term care ombudsman, and I'd say families, are key. And I do believe that it's helpful if you can build a base of attorneys, and I'm happy to help you to do that and try to help to really get people more interested on taking these cases. One of the questions that just popped up I saw was, how applicable is this to hospital settings? Incredibly, incredibly common in hospital settings and in assisted living. But Robin's dad was first prescribed antipsychotic drugs in the hospital. And I think it's important to, when people go into hospital and then they get sent out to nursing facilities, sometimes nobody even questions, why did that prescription suddenly come on to the list of prescriptions? And doctors in the nursing facility and nurses in the nursing facility should also question why a hospital has added that added medicine. But you'd be shocked to know, maybe you guys wouldn't be, but I was a little shocked to know how little communication there is when someone's discharged from a hospital to a nursing facility. No one at the nursing facility asked why Mr. Tweed was put on those drugs in the hospital. Nobody asked at all. They just started giving it to him, and without question. So Robin, Lori, did you want to open up for questions?
I'm going to go through some tips for some residents and advocates, kind of to bring us back to some of those, and then we'll open for questions. So, Katie, if you can move on to the next slide, please. Even after this, because we've talked about a lot of different things today in terms of information, as well as some of the strategies and tips that both Kelly and Robin had talked about, and I wanted to coalesce them as we are moving forward a little bit, and then we'll get to some questions. So thank you, Kelly and Robin, for your excellent presentations. First of all, I think it's really clear that we really need to be paying attention to the drug regimen and any changes that are taking place there. And Robin really mentioned that as well in terms of being very carefully looking at the drugs that are prescribed and being taken by the residents and asking questions about each of them. Why was it ordered? What are the side effects that are attributed to it? What are the interactions? Watching how the person responds to that drugs. All of these things are really important. Having scrutiny of all of the drugs, because not only do the antipsychotics have some dangerous elements themselves for people with dementia, particularly when they're being used off-label, but they could have different side effects with some of the other drugs that the residents are taking, and you really have to be careful about what they might be. So paying attention to the drug regimen and changes are critically important. Next slide, please. Recognizing that you should be giving consent, and that's really a part of the fact that individuals have rights to direct their own care, to refuse medical treatment. Certainly they have the right to protection from unnecessary drugs. That's very clear in the nursing home regulations that are available for residents. They have the right to individualized care to meet their needs. And so any treatment or care that you're getting should be to help you maintain the highest or attain the highest practicable level of being. And so they should be being prescribed for you and being used for that purpose. And if they're not, then there are real problems with that. And families and their advocates for residents really need to be aware of that. But this is one of the reasons why certainly consent is critically important. Next slide, please. When you do have concerns or questions, certainly you can be asking for closer attention through the assessment and care planning process. For residents in long-term care facilities, they all must have had a full comprehensive assessment from the time that they have been living in a nursing home. They must have a care plan that's put into place, and those must be evaluated and updated on a regular basis, quarterly basis, but also if there's some sort of change in condition or if there are concerns, they should be reevaluated and updated. And families can be asking for reevaluation in these cases. If certain strategies aren't working, then what else can you try? And that's what part of the care planning process is. A care plan shouldn't just be written one afternoon and you figure you don't have to look or touch it again for another quarter or 6 months or year or whatever the time frame might be, but certainly it should be an evolving process, and it should be adapted and adjusted based on the needs of the individual. And if certain things are not working, then you need to go back and look at what wasn't and how can the care plan be adjusted in order to put the plan in place that will work for that person. They definitely need to be based on the resident's needs. That's really critically important. And as a reminder, and Kelly mentioned this before, looking at what are the symptoms and the behaviors that are being expressed by the resident. What we need to remember, particularly in residents with dementia who may not be able to verbally communicate, or with residents, even if they don't have dementia, that may not be able to verbally communicate. Behavior is also communication, and we need to be looking at what are the symptoms or the behaviors that they're expressing and evaluate what the needs are. Are they in pain? Are they afraid? Are they bored? There are a lot of reasons why people act in certain ways, and getting at the root cause of what that issue is and treating that that cause, rather than trying to just quash the behavior or quash the action that's being exhibited, is really critically important. And it could be related to medical causes, it could be related to psychosocial causes, and even environmental causes, because as we know, many people respond very negatively if there are loud noises or lots of activity around. Sometimes you just need calm and quiet. And so there are lots of reasons why a person may be showing different behaviors. Next slide, please. Certainly, residents and family members need to know their rights. And Robin, I think, is a perfect example of the fact that not only did she know and educate herself about what her rights were and that of her father, but she was able to put them into practice. And so it's really important to know what your rights are. The fact that as a resident of a nursing home, there are federal rights and state rights that apply to you that include some of them that are listed on the screen. You have the right to quality of life, to maintain and attain your highest level of functioning, to be treated with dignity and respect, to refuse care and treatment, to have individualized care. There are just a whole slew of them that contribute to the type of care you're supposed to receive, that you should expect to receive in a long-term care facility. And by knowing your rights, you can be better positioned to ensure that that your rights are being followed and respected, and that you are getting the care that you deserve and should expect. Next slide, please. We talked about knowing about the drugs that are being prescribed, but also being educated about the diagnoses that you have. And that, again, goes back to, Robin educating herself about not only the drugs, but the diagnoses that her father had, looking particularly, as Kelly had mentioned, if there are changes in diagnoses or one suddenly appears on the records that you need to be questioning. What is that all about? It's very unlikely for a person to develop schizophrenia in their 80s, for example, and yet we are seeing that new diagnoses of schizophrenia are occurring all over the country in elderly people who never had that history before. And so you need to be questioning the diagnoses, asking what are the symptoms, what's the progression of the diagnoses that's there, what are the strategies for care, asking questions about all that, and also looking at if there are changes, making sure that you know what that's all about and why they have been added to the person's record. Next slide, please. Become empowered. Asking questions is really critically important. Sharing information with the staff and the caregivers about the resident, what their habits are, what their likes and dislikes are, what their life history is. All of that certainly should be shared, not only during the assessment and the intake process at the beginning, but throughout. I mean, it's important that they know as much as they can about the individual, particularly if that person can't communicate themselves, so that they have a better understanding of what might be causing different either behaviors or different responses to different events, and they can be better likely to find a solution that does not include drugs. So it's really critically important that you feel empowered to be able to ask questions and to share information so that you can, again, get the best care possible. And certainly asking for help. We have that here from not only the facility staff and administration, next slide please, but also getting help from your doctor or practitioner. We did notice that that there was a comment that you don't often see the doctors in the nursing homes, but it's important to be continuing to reach out to them whenever possible. Again, they have a responsibility for monitoring the care and directing the care that the resident is receiving, and so they, just because they're not in the facility doesn't mean they still have the responsibility. They need to take that responsibility, and they need to be held accountable as well. But also you have other resources such as the Ombudsman program, which is there to provide supports to you, and you can find your local Ombudsman program on the Consumer Voice website, and the web address is right there. And also the State Department of Health, which oversees nursing homes. You can file a complaint with them if you have concerns about the care. Next slide, please. We are, as part of this campaign, developing, as I mentioned at the beginning, some additional resources and information, and have created the beginnings of a consumer webpage where we'll be continually adding new information and new useful information for consumers that they can use when they have concerns about this issue, or to educate themselves about not only the use of these drugs, but also about good care practices, and also where to go for help. And folks will be able to access that on the Consumer Voice website. So with that, why don't we turn to some questions? And I know a number have been coming in, and I'm going to take a look through them. I know one question that had come in was, when the Department of Health does a survey of a nursing home, do they check medical records to see if the wrong drugs are being given to residents? And Kelly, I was wondering if you had any comment about this, and I can also comment on this as well.
Yeah, I mean, when the state surveyors come in, they'll just draw a sample of people, and they'll pull the records of those individuals, but it's just random selection. So yes, they would look at medical records, and they do, facilities do get cited for prescribing drugs that are not supported by a diagnosis, but it's catch as catch can. And I would urge anybody that encounters this, either as a family member or an ombudsman, to make a complaint survey, or a complaint about it, because then the state is obligated to go in and investigate the complaint. We need better data on this. It's not sufficient, this hit or miss process where they just randomly select a bunch of files, where it might or might not be diagnosed, might or might not be clear from the records that a person is on antipsychotic drugs without a supportable diagnosis. So but even when they do find it, oftentimes the state surveyors are not finding actual harm from that, which to me is absolutely befuddling. That's why I think if we do more of these complaints, and drive the states to have to investigate these, and you identify the harm yourself in the complaint, I think we'll get some better results. I think that states are saying, no harm, no foul. He got Zyprexa, yeah, he didn't have a diagnosis, but it did quiet him down. He's not as disruptive now, so, no harm. But that's inappropriate. That's a chemical restraint, and it should be, I think it should even be an immediate jeopardy, because look at the consequences. Death can be the consequence.
Mm-hmm. Absolutely, and I think filing a complaint with the survey agency when you have concerns is really critical in order, as you mentioned, to record that this is going on, but forcing them to look at it more deeply. And this is an issue that we know that additional advocacy needs to be done both with the state survey agencies and with CMS in terms of the investigation of these complaints, as well as how they're coded for scope and severity and the type of enforcement that's put into place. And so I know we at Consumer Voice, in partnership with a number of different organizations, have been working on that with CMS and the state survey agencies. I know Ombudsman programs have been working on it as well, and it's something that we all need to certainly continue. So another question that came in from a volunteer ombudsman is they don't have access to medical records, and certainly ombudsmen need consent in order to look at a resident's medical records. So how can ombudsmen advocate for residents that they suspect are on non-appropriate or inappropriate drugs?
That's a great question. I would start with asking questions. I mean, you can ask questions about people, casually, even like, Mrs. Jones looks a little bit like she's dropped a lot of weight. Is there something I should be worried about as the ombudsman? And see if any of the staff will talk to you. I think that another way of doing that, though, would be to go to the ombudsman's office and see if they can, or if you can get authority to get a release on behalf of that resident. I think that this is so critical. It requires that we do what we can to figure out what's actually happening. I think that when you see especially if you go into a facility where you see a bunch of people who are really sleepy and restless and agitated, and then there's usually a pattern of inappropriate use of these drugs, and that might even warrant a system-wide complaint. Just asking without even naming individuals, like, please, can we sit down with the facility and just ask, like, how many people in this facility are getting antipsychotic drugs without a diagnosis that supports it?
Absolutely. And as Ombudsman, and frankly as family members also, you can, through nursing home data, that's available through CMS, and we can share more about this with all of you, but you can get the rates of antipsychotic use in the specific nursing home so that you can see what those rates are, and you can be asking questions of the staff and administration about their use. What other practices are they employing in order to avoid the use of these drugs on people with dementia, and often also to share resources for training or best practices, because there's so much information available not only on our website but on a number of others, and we have a whole list of resources not only on this new consumer site that we're developing, but we have an issue page on antipsychotic use on the Consumer Voice website as well. Okay, let's see what other questions we have here. There were a number of questions about the slides that were available. There is a link in the chat box, and Katie, maybe you can add that again in the chat box so that it's fresh, so that people can link on it. But we will also send them out after the webinar and make them available along with the recording, and they will be posted to the Consumer Voice webpage so that you can access the slides as well as the article that Kelly referenced, and some additional materials that we have on the page. And then I think the last question that we may have time for today is, will we be sharing information on state laws and state legislative activity on this issue? And we know that there are a few states that have done some work around passing informed consent laws, and that is something that's being worked on at the federal level as well in order to try and get federal legislative language around informed consent. Kelly, I don't know if you had any more to add on this. We could certainly follow up and add more information.
I mean, I think it would be great if we could sort of take a hard look at, I know that there had been some work by folks at Canner and other places in California to kind of put together a list of how all the laws sort of break out in terms of who has informed consent things and who has private rights of action, and what are the rules around informed consent and drugging. AARP has put out, they have a model bill that they're trying to promote in states, and I think we can ask them if they are willing to share that with folks. But if they're, I really do think it's key that we strengthen the state laws as well as the federal law, because the state laws are what allow for the kind of lawsuits that we've been able to bring. And not all state laws are created equal, and that gives rise to whether you can get counsel for people on these issues. But I do think it's critical that we continue to bring lawsuits. I don't just say that because I'm a litigator. I just think that's one really important way that we keep this laser focus on this issue, that we keep bringing these stories forward, like Robin and her dad, that this is, the human consequences of this are terrible, and we need to be able to get these stories out.
Absolutely. And Kelly, you had mentioned that you also are willing to either talk with people or help think about ways to get other attorneys engaged yes. in these cases. Katie, if you could go back a few slides to Kelly's contact information, if you don't mind, and so folks could see that, and we'll also share with you the information for people who have asked for more information about legal support on this issue. There have been a few that have come in through the comments as well.
Okay.
So with that, I would like to thank Kelly and Robin for your excellent presentations and participation today. I think that this was such useful information that we've been able to share with folks. And as I mentioned, the recording and the PowerPoint will be available for download and on-demand listening from the website, so that you certainly can share it and use it with your networks as well. And we will be generating new and additional information over the coming months that you'll be able to use with residents and families and with your ombudsman and advocacy networks in your communities, so that we could get as much reach as possible on this issue, raise awareness as much as possible, and really look to affect change on this. So Kelly and Robin, thank you so much.
Thank you.
So glad to have you with us today. For those of you listening, look for additional information and resources, as well as additional webinars and programming we'll be having over the next year. And I hope all of you have a very happy holiday, and we'll be closing now, and we'll look forward to talking to you again soon. Thanks so much. Have a good afternoon.
Thank you.
Thank you.